Welcome to the Friends of NPACE Podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Welcome, everyone, to the Friends of NPACE Podcast. I'm very excited about our podcast today. As you know, I'm Terry Schmidt. I'm the Executive Director of NPACE. I'm also a practicing family nurse practitioner, and this is a sweet spot for me. This particular podcast is going to have continuing education credit, in part due to a generous grant, education grant from Novo. So I'm super excited to introduce today's guest. This is Gary Graf. He's a nurse practitioner from Topeka, Kansas. He started out practicing in family medicine for 3 years, but has done diabetes and endocrinology for the past 20 years. During his 21 years of practice, he simultaneously did urgent care on weekends like all good nurses. He's always had more than one job. He's been the sub-investigator for over 350 clinical trials in the field of diabetes, hypertension, diabetic kidney disease, as well as many cardiovascular outcome trials. He has inserted over 350 implantable continuing glucose monitor devices. Oh, CGMs, nice. That'll be another episode, Gary, that I totally want to talk about. And he and his wife have 10 children together and 8 grandchildren, and his hobbies include camping and fishing. You got to take those grandkids out camping. And he's climbed 50 of the 58 Colorado 14ers. That's impressive. Welcome, Gary. Did I get it all?
You did, all in one breath. I'm so impressed.
Thank you. Well, I get pretty good at reading here. So welcome. Thank you for being here with us. I love this topic because I've practiced in endocrinology, primary diabetes. I started peds years ago with the University of Missouri because we had no pediatric endocrinologists in the Ozarks. And so we set up a satellite clinic. But there's so many adults with type 2 that I just ended up, gravitating there. So I, in season 2, am actually starting with a unique question before we get to diabetes, and that's, how did you end up in nursing?
Oh, that's a good question. And I think sometimes when we get older, we start going back, how did I ever get here? That's true. And so I started out at the University of North Dakota, and I was thinking, well, maybe I'll think about pre-med. And all of a sudden, I had my first child. And I was like, wait, this was unexpected. And so one of my friends was going through nursing, was thinking nursing school, and said, you'd make a really good nurse. Why don't you think about that? And there wasn't very many male nurses at that time. And so that's exactly what I did. We ended up moving to Topeka, and I was attending Washburn University and immediately got activated for Desert Storm. So,
oh, gosh.
Yeah, right within the first year of being here, I was gone overseas. I was in charge of a 6-bed operating room, and we had a lot of patients. We had 7,000 patients that came through our hospital. Came back, finished my nursing degree, and part of my deal was I had a VA scholarship, and I had to go work at the VA, which I was already a veteran, so I really appreciated that. And believe it, back then, there was actually World War II veterans we were taking care of. So it was quite an experience to see that. And we still had, IV poles. You counted the drips.
Yes.
And, the veterans would go outside and smoke, and they'd have their oxygen on and things like that. It was really just a great place to understand what nursing was like, I think, before computers took over.
Yes.
So my family was growing, and I decided I probably need to go and get some more education, but I didn't know what to do. Again, nurse practitioners were pretty new at that concept. I think they had certified nurses or something like that, CMNs, I don't remember what they were. And they could write some prescriptions under very limited authority. And I remember working the night shift, and one of my nurses that was working underneath me, she was a single mom of 6 kids, and she had raised those 6 kids. 5 became doctors, and 1 became an orthodontist.
Oh, goodness.
Yes. And so she said, Gary, you should go be a nurse practitioner. and I didn't even know what it was. I looked into it, and again, with the large number of kids, it took a long time. It took me 5 years to get a 2-year degree, just because I was kind of taking a class here and there, and then graduated, like you said, did family practice for 3 years, and now I'm on my 21st year in diabetes endocrinology. So it's been an amazing ride.
Well, we're glad you took that ride. That's very interesting. What's interesting to me is everybody's story has been different about how they got here and so varied. I love that you practiced at the VA and did drip rates. Remember those? Before we had pumps, we used to actually hold our watch up kids to the drip. Yep. Yeah, good. Well, I appreciate you sharing that with us. And then 21 years in diabetes, which is going to lead us right into our topic. Because so much has changed in the world of treating type 2 diabetes in adults. And I actually heard you say this last year when you updated us on 2024 guidelines. Just the last decade has been crazy for how things have changed, for lack of a better term, crazy in a good way. So we talked a little bit before the show, but why don't you take us on the journey on how we got here to the 2025 guidelines?
Sure. So to understand the 2025 guidelines, we actually need to go back to 2007, 2008, around that time right there. And I was pretty much a new nurse practitioner, so I remember this. And there was Dr. Neeson. And Dr. Neeson was kind of this watchdog doctor that said, oh my gosh, these drugs are good, these drugs are bad. And he had identified Vioxx and Avandia as being bad drugs. And he was right. They actually took both those off the market because of his research and or his, let's just say complaining. He was very loud and very vocal about it. And Avandia was one that the FDA really looked at. And so a year later, in 2008, the FDA came up with this major statement. It said, guidance for industry, you will now start doing phase 4 diabetic clinical trials with all the drugs that are already on the market, and any drugs that are in the pipeline, you're going to do these phase 4 clinical trials. Now, phase 4 clinical trials means it's already been found safe, it's already on the market, or will be on the market, but we want you to take a whole bunch of people, 4, 5, 6, 14,000 people, whatever it takes to get the numbers. Half will get your drug, half will get placebo or standard of care. We don't say placebo because they still would have to add on, maybe say insulin to get their blood sugars. And we're going to look at them and see who has more heart attacks, who has more strokes, who has more cardiovascular deaths. And so from 2008 up until 2015 or so, all those drugs that were in the pipelines were safe. They didn't cause any more deaths. They didn't cause more strokes or heart attacks. And okay, everybody was happy. But what happened, we saw, was because you're putting all these people in clinical trials, the prices of these drugs are going up too. So you do see a big shift in that. If you were practicing in the early 2000s or something like that, we're like, this is really, really expensive compared to $100 or $150 a month for drugs. And I'm not 100% sure that's the reason why, but it sure is a funny correlation why it was. Yeah. But amazing, in 2015, the New England Journal of Medicine, the first cardiovascular outcome trial that actually showed improvement was announced. It was called EMPA-REG, and it was used with empagliflozin, and it showed a 38% relative risk reduction of cardiovascular death looking at the 3-point MACE, which is, again, stroke, heart attack, and CV death. And I was actually in San Francisco at the ADA meeting, and it was a standing ovation. People had never dreamt that these drugs would actually save lives and prevent cardiovascular death. A year later, the LEADER trial came out, again showing that the people that got liraglutide had less cardiovascular deaths. And then a year later was REWIND, and so on and so on. And so that's almost the expectations now, that these drugs not only are safe, but they actually may even help out cardiovascular death. Well, there's something that's really interesting when you have 5, 6, 7, 14,000 patients being looked at. You start to see other things like, hey, this group of people here had less end-stage renal disease. Hey, these people here had maybe less heart failure or recurrence for hospitalization for heart failure. So the companies, we're going to do another clinical trial. And they pick out another 6,000, 7,000 patients, and they say half are going to get standard of care, half are going to get this new SGLT2, half are going to get this new GLP-1 receptor agonist, half are going to get a GIP. And again, you start seeing, wow, we have other indications. So now we find out that some of these drugs are not just great for lowering blood sugars, which insulin has done a great job for years. But now we can actually see people lose weight. We can see people have less congestive heart failure. We're actually putting the brakes on end-stage renal disease and going on to dialysis. So answering your question after that long explanation, now the ADA guidelines are so much more than they were, say, 8 years ago. It was, 6 different categories of drugs. Pick the one you like. Versus now you say, okay, they have diabetes and I want to get their blood sugars under control, but what else do they have?
Mm-hmm.
Do they have congestive heart failure? Do they have obesity? Have they already had a heart attack? Have they already had a stroke? So you start thinking, okay, the next drug after metformin, there's got to be one that's going to help them out in that way too. And it just gets better and better. It really does. 21 years ago when we were doing clinical trials, and like you mentioned, we've done a lot of clinical trials, we were putting into a basal insulin trial at that time, easily 10 people every 3 weeks. No problem. Basal insulins were the rage back then.
Mm-hmm.
People were getting off of NPH and Ultralente and finding out, hey, we can give them 1 shot of insulin per day, change the way we practice. Now, 21 years later, we're doing clinical trials for once a week insulin.
I know.
We have like 8 people in that trial. We just don't put
amazing.
people on basal insulin like we used to.
No.
And it's just been amazing.
It's going to be amazing. It is. The once weekly insulins are coming, and I'm so excited about that as well. Insulin used to be the go-to, insulin and metformin, but I still would have patients who I just couldn't control blood sugars on. And I didn't have the pathophysiology knowledge at the time to understand that sometimes we were making people worse by increasing insulin, and that pathway of resistance was just more complex because we kept dumping insulin on them to try to get their blood sugars down. But insulin is fantastic. I don't want to say that it's not, but I appreciate you saying that. And so we started with cardiovascular, and then we found kidney, right? All of a sudden people's albumin levels were lower and their urine creatinine ratios. Now we're going to move to liver effects, right? That's going to be the next phase of exploration.
You are correct. We are doing trials right now for NASH and how some of these drugs not only help people just lose weight, but they're having to reduce their liver, or helping to help out their livers as far as getting rid of fatty liver disease. And they're even doing clinical trials for dementia and Alzheimer's with us. Not to say that there's any indications, because there's not right now, but there's a lot of people still thinking that, hey, what else are these drugs doing? And so what a great opportunity to turn, okay, Dr. Neeson was complaining that it was killing people. Now we're actually saving so many different lives, and they're living so much better too.
Yeah, it'll be interesting to see, because we know the pathway, the endocrine pathway for this insulin resistance, for incretins, for DPP4 is on every single cell in the body. There's got to be impact. I mean, we're just finding that now. One of the other things, and I'm going to go way off topic here, which our audience doesn't know, that came out this year in the updates was bone density and fractures. If we'd had people on sulfonylureas or they'd been on insulin long-term, which is nothing that we had considered 15, 20 years ago in practice, because the endocrine system is way more complex than I think we give it credit for. And so just like managing someone's thyroid has a total systemic effect, I think we're going to find managing more than just blood sugar, that incretins and some of these other hormone balances in the body are going to be revolutionary in our understanding. Yep. We could say we were alive during this.
Well, I said that when I have students, I tell them, I say, I wish I was your age, because I'd like to see what's going to happen for the next 25 years again, because it's just been such a big zoom, and I won't be around to watch that. So I say, you're in such an amazing position when I have a nursing student or a nurse practitioner student say, man, just remember this discussion, because you're going to go look back and someone challenged you to think ahead.
Yeah, completely. Between that and continuous glucose monitoring and the technology, like I remember when the A1C technology, I mean, I was practicing then with a clinician who'd been in the DCCT trials, and just how far we've come in monitoring that match and what we know that's going on physiologically. So you're right. A good
Yep.
time to be a practitioner. So I do want to hop into the drugs, but I want to talk, you talked about the 2015 event that you were at the ADA, which was an SGLT2 drug, the first in that class. Let's talk a little bit about what's going on with that class, when they're recommended, and any
Sure.
prescribing pearls.
Yep. So prescribing pearls of our SGLT2s, you have to understand how they work. They're basically taking the threshold level of where you normally would urinate off sugar, which in type 2 diabetics is upregulated. So they may hold on to sugar to like 200 or 220 milligrams per deciliter. It knocks it down to almost 100 milligrams per deciliter. So they have a core defect that they're holding on, just like everything else that a type 2 does. They do bass backwards. Instead of peeing off sugar, they actually hold on to it until it's too much. So now with the SGLT2s, we lower that gradient to much closer to like 100, 120. But it works in a glucose-dependent way. If you're following your diet, you're doing a great job, you're not going to be urinating off that much sugar. You go out to that great seafood restaurant and have one of those cheddar biscuits, which leads to 4. Well, guess what? You're not gonna bash that restaurant. I like that restaurant, but those cheddar biscuits are darn good. You'll be peeing off that sugar, and with that, it's also pulling sodium too. So as you're doing that, instead of thinking, well, urinating off sugar is a bad thing. No, urinating off sugar is a good thing. It's actually helping to protect the kidneys. And as we do that, then we're also reducing the load on the heart, helping out congestive heart failure. So some pearls for those are, in general, they have to have a reasonably good functioning kidney for it to work. So there is a GFR for it to work for glucose removal. It's just offloading glucose. And in general, the GFR, about 45 is where people decide, hey, maybe this drug's not going to be as advantageous. Your A1C reductions really are much less between 45 and 25 than they would someone who's 60 or 70 on their GFR. It's just mechanical. It's a mechanical getting away of sugar. People do urinate off up to a candy bar worth of sugar, so mild weight loss, which everybody likes that, 5 pounds of weight loss. But in general, it doesn't continue to lose weight. And so using our skills as practitioners, we can say, hey, you might lose 5 pounds on this drug. Maybe they'll lose more. We always look for those kind of things. But in general, this would be your second line agent for people that have type 2 diabetes that maybe could lose a little bit of weight, who may have some heart failure issues or kidney disease.
Yes.
Okay? And not really bad kidney disease. Now, as these drugs have been explored, they're finding out that the protection of the kidney can actually go down to that 25 or maybe even lower on their GFR. So they're not getting the glucose lowering effect, but they're still getting the kidney protective effect. So
almost like when we used to say, give an ACE, a low dose.
Yes, very simple. Yep. So, and then other pearls would be, you are urinating off sugar. You got to keep that area clean. For our women, if they're getting yeast infections, they're getting urinary tract infections, think like when you were in your nursing school. Get the Pericare bottle out after you're done urinating. Just squirt some water down there and then pad off. For our men, super important to ask if they're circumcised. Literally, every man that is not circumcised who gets a yeast infection will think that their partner is cheating on them. I'm kidding. But
they don't want to experience that in any way, shape, or form.
They don't.
Yeah.
Man is a wimp. If they get a yeast infection. So
They are.
Important to ask and to provide that education about keeping themselves clean.
Yep. UTIs is a big one. The other thing that's come up with these, although they're fantastic drugs, I love them because they're oral. People who are needle phobic, they do get a quick response. We get a good A1C. They can kind of see quickly and get that good positive feedback loop. But hyperglycemic DKA.
That's a great question, because when we look at all these clinical trials where you have large numbers of people, they have this term, it's called euglycemic DKA.
Mm-hmm.
And so this is a real good thing to remember to protect your license, number one, because we never want to hurt people. And number two, to understand again how it's working. So in some of the clinical trials, it was noted that these people were all type 2s, but maybe some of them were behaving more like LADA or type 1s, very insulin dependent, very much not overweight. And so there was a small group in some of these trials where they call it euglycemic or fairly normal blood sugars, and they're going into DKA.
Right.
And they also seem to associate this with being sick or being dehydrated.
Right.
So should you have a patient that remotely looks like that, you have to remind them, if you're sick, maybe don't take that pill. If you're low on volume, keep your volume up, because this could lead to DKA. There was a company that was trying to have an SGLT1, SGLT2 that was primarily for type 1s, and I think that drug is still stalled. But again, the drug would work for them, but the hang up there is we don't want people to go into DKA. And so very rare, but just some education on how the drug works will help keep your patients out of that problem.
Nope, I appreciate that. It's almost like sick day planning, like we would do with insulin.
Yep.
Stop it if they're going to go to surgery at least 3 or 4 days ahead of time and have a sick day plan, right?
Yep.
If they're going to hold that. Or if they're fasting.
Or if they're fasting, yeah. The drug it's not going to work. You don't need to take it anyway.
Yeah, if you're not eating, that's going to be a moot point. Okay. Nope, great class of drugs. And again, there's no tier order from the ADA on what you should choose. It's if you have a patient who has some renal dysfunction and maybe some heart failure and issues or risk of MACE, this is a great drug.
Great drug. Great class of drugs. They all are just great. Everybody goes out there and does their renal trial. They go out there and do their heart failure trial, and guess what? They all do it. And we didn't see that before. And so it's, and we've talked before, these drugs are expensive. So you want to be able to get your big bang for your buck too. We want someone to make sure that it's not just, oh, I really like the purple pill. There's a reason why we're choosing this. And is it heart failure? Is it to protect their kidneys? It's probably not weight loss in this class of medications, but it's certainly not going to cause them to gain any weight.
Right, which is always important as well. So I think good points. Okay, I do want to move over to the most popular drug I get requested by all patients anymore, and that's that GLP-1RA group. Talk a little bit about that, why we prescribe it, pearls, cautions.
So this is probably the biggest thing that's happened to type 2 diabetes for sure in my career, and that is our GLP receptor agonists and now GIPs, which is one GIP. So we want to get that out there. These drugs are mimicking the drug or the hormone that's already in our body. And so when I teach my patients, I say, hey, I want you to imagine that you're going out to a French restaurant. You're going to have the 8-course meal. It's going to take you an hour and 10 minutes to eat it. And when it's all over, you only had 900 calories. And they're like, well, that was a delicious meal, but we didn't eat very much. But the weird thing is, because they ate so slow, the little soups, the little salad, the little portions, because they ate so slow, they're not hungry. And that's because their body made its own incretin hormones, its own GLP-1, its own GIP, some other incretins too, that turn off our ability to overeat, hit the satiety section of our hypothalamus. Now, we're in Kansas. We're going to go out and get a roller dog afterwards because darn it, we got ripped off. That was $150. But the opposite would be going out to an all-you-can-eat buffet and you have 3 passes in 25 minutes. You feel miserable. That is our body's own incretins not having a chance to start working, telling us to stop. And so 2000, let's see here, the Gila Monster spit would have been probably 2012.
I remember that.
Yes. Who let their gecko out? And I don't know, but they found out that this lizard spit actually mimicked that same hormone, GLP-1. Then we came up with our analog ones and we made our own, and there's been other changes since then. These drugs are amazing. They do 4 things super well. Number 1, hitting the hypothalamus, you're full faster.
Yes.
Next, slowing of gastric emptying all the way from your mouth down to your bottom. So food hangs up there longer, you're less likely to eat. Number 3, telling those beta cells, we love you, let's make insulin now.
Mm-hmm.
We're done eating, let's stop. So preserves that beta cell function.
Yep.
And then lastly, turns off the liver from misbehaving, dumping in sugar when it shouldn't be. Meaning basically type 2 diabetics, again, do everything wrong, backwards. They could be eating cheesecake and their body is still dumping in its own sugar. So
Right.
it really is that, turning off that glucagon. And so these drugs here, again, explaining to our patients how they work. You might feel full faster, probably will. You might feel like you don't want to eat, your satiety. You're going to make insulin in a food-dependent way, and you're going to turn off excess sugar your body's making. This allows you to have amazing control over your type 2 diabetes with a very likely side effect of weight loss. And we love that.
Yeah, it's a fascinating group of drugs. And so I do have to screen patients and talk to them. They're so enthusiastic about it. But I'm also impressed with what it's done with some of the triglyceride levels in my patients who are no longer, their body's not breaking down and storing fat, but also breaking it down at that high rate or dumping all those glucose stores. I think we'll be prescribing some of these for cholesterol levels in the future as well.
And the new slide decks are showing just that, a drop in triglycerides, a slight rise in HDL. Will it be indicated for it? We'll have to wait and see. But again, who couldn't use a drop in their triglycerides? And so these drugs just keep getting better and better. We started out with the Gila Monster Spit twice a day, then once a day shots. And I was a big no. It's a once a day drug. You should take it once a day. And then they came up with the once a week, and I was like, nope. You have a disease that's once a day. You should always take it every day. Well, guess what? Patients like to take it once a week. Mm-hmm. And as it keeps getting better and better, we're seeing even more A1C reduction and even more weight reductions, such that these drugs now have a new label for weight loss.
Right.
And we can thank Dr. Oprah and Dr. Sharon Osbourne and maybe Dr. Kim Kardashian, I don't know, for helping to sell this, because everybody wants it now. And to include, your compounding pharmacies that are out there trying to mimic this. And so I hope I didn't open a big can of worms, but I definitely think it's worth talking to our end.
I do want to talk about that. You didn't open a can of worms. I do want to talk about oral versus injectable, because I have a lot of patients who are needle phobic and go, oh, can I take the oral? I'm like, oh, good. It's more complicated than taking thyroid medicine, right?
Yes, yep.
If you can tolerate an injectable, like that needle phobia is real, but it's not as bad as you think it's going to be. So talk a little bit about the oral, and then, oh, good, I want to talk about compounding pharmacy.
Okay,
so
sure.
I'm glad you brought that up.
So of all the GLP-1s and GIPs that are out there, there is one oral. There's more coming. We're doing clinical trials on the other orals. Would not be surprised you see another one in the next 18 months for sure. And they're probably even better than what we have. So just hold on to your shoes here. But there is one oral. It is the exact same molecule of the subcutaneous. I'm not sure if I can say brands here or not. I'm trying not to, but if you do the math on it, okay, it's Rybelsus. If you do the math on it, and it's Ozempic, 98% of the oral pill is wasted.
Yeah.
And so what the oral pill has, it's called snack technology on the outside. It actually gets into the stomach and is passed through the stomach lining, right through the villi in the stomach. That's where that transfers at. So that's why you have to take it. Like you said, it's almost more difficult than levothyroxine. Right away, first thing in the morning, small sip of water, nothing else for 30 minutes. The pill's got to be held in a humidity-free container. You can't put it inside a pill organizer. So it's a little bit of a hassle compared to a once-a-week shot. You're actually correct. But for our needle phobic folks, hey, this is a perfect drug. But it has the exact same A1C reductions, the exact same weight changes for the most part as does once weekly Ozempic. If you do the math on Ozempic 0.5 milligrams weekly or Ozempic 1 milligram weekly, if you waste 98%, That comes out to the 7 milligram pill or the 14 milligram pill
Gotcha.
times 7 days. You're just wasting 98% of it. Yeah.
Okay. Nope. I appreciate you saying that. Yes, celebrities taking the drugs for weight loss, or I have a lot of patients who just want to do it. I just want to take it for a month or two, not understanding that when we change the endocrine system, we likely need to change it forever. I would never get your blood pressure under control and then stop your blood pressure medication. But that's leading to compounding. So let's talk about short-term prescribing and then the problem of compounding pharmacies.
Yeah. Well, you're right. These drugs are not meant for just a short term. I want to be on it for 6 weeks because I want to lose 3 pounds. That's not what they're meant for. Obesity is an epidemic in the United States, across the world, but certainly here in the United States. These are meant to be used long term. And so this is not going to be a short term pill or a short term fix. And so that's not very appropriate. Again, last year and a half ago or so, these drugs exploded for weight loss. They just exploded. You couldn't find them anyplace. And then also you couldn't get the same molecules for our patients that needed it for type 2 diabetes. So the major companies ramped up production, have done a great job of getting all the doses filled. But during that time period where they didn't have all those doses available, I guess there's some type of FDA clause where compounders can come out and compound, I'm going to say the word replicas very loosely.
Okay.
Because I really don't believe that they are exactly the same. I don't know where they're coming from. I don't know how you could compound it. And I also don't know how all these major companies spend, so much money on making sure they're safe and that they work, and that the compounders don't have to do any of that.
Right.
And so I have never written for a compounded incretin GIP or GLP-1 receptor agonist ever. I would not feel good putting my name on that. And I'll even challenge you one more, and that is, if these drugs were so identical to the parent drug, if there is such a thing as a parent drug, you would think your large PBMs would say, no, we're not going to pay for Ozempic. We want you to pay for compounded Ozempic, which is so much cheaper. Not one PBM has said that. So
right.
Yeah.
In fact, the FDA continues to make statements. Was it last week they just made, or the week before, another statement about compounded GLP-1 RAs and avoiding that? And I would think, as a clinician, my license might be on the line with some of those.
I would think so. I would think,
Yeah.
So hopefully those kind of evaporate soon. But my impression is some of these weight loss clinics, and just an impression, they bought it by the 55-gallon drum. They just have stockpiles of it. So even though the compounders can't make it, these weight loss clinics probably have a supply for it for quite some time. And so I would bet at some point those prices will start to go up, and we'll see a big change, just going back to normal, I think.
Yeah. That's a good segue into price. So I deal with a very uninsured, underinsured, state-by-state Medicaid, which changes population. Let's talk a little bit about cost and accessing meds like GLP-1 RAs. How do we do that?
You bet. Well, as you know, type 2 diabetes is probably one of the most expensive diseases you'll ever have, that hopefully you get to live for 40 or 45 more years, okay? And I tell that to my patients too. Sure, insulin's out there, and insulin's now cheap, it is, but there's so many more reasons why we use these more modern drugs. And so number one, hopefully it's on their formulary. And it was January 1st a few months ago. Formularies have switched. Oh, we're not on this formulary, now we're on that one. Somebody slept with that company, someone didn't sleep with that company. Now you got to change.
Yeah.
You got to provide all that documentation. But usually if you have private insurance, there is some coverage, or maybe really good coverage. In fact, generally we see very good coverage for your commercially insured. Your Medicare patients, it is harder. Now with the new Medicare caps of $2,000, hopefully that would be something that would make sense. And most of these people who are on these drugs are also on other expensive drugs too. Yeah. So you just say, well, you're going to spend your $2,000 one way or the other. And then with Medicaid, that is also state by state, as you know, very difficult to change that. But again, fortunately, there is insulin. I am a big coupon person. This is no lie. By my rooms, my exam rooms, I have all these different things on the wall with coupons and education. And the thing I bought years ago was an electric stapler. So when we went electronic prescribing, nope, I still print it off on the 8.5 by 11 piece of paper, grab the coupon, use the electric stapler, staple it to the prescription, because there's been data that shows only 11% of coupons are redeemed. Mine's got to be 99. If you don't redeem a coupon, you never even tried. And explaining to them, hey, they want to make sure that number one, you are a type 2 diabetic. You're not just using this drug because you want to lose weight. And then, are you a U.S. citizen? Are you adult? These things are not hard questions to answer on these coupons. And you might get this drug for $25. You might get it for $100 off or something like that. In fact, we're in Kansas. I like my stapler so much that if there's a tornado that hits our building, I'll always rescue the stapler before I rescue anybody else. So that stapler
first.
It's a gem. Yeah.
But I love that. No, I think coupons are important. I practice telehealth, and I actually have a list of starred and clicked links that I just send patients. Go here first. Look at this first. And I will say, even some of the mail-in pharmacies, have been fantastic for great drug prices. There's an SGLT2 at Mark Cuban's pharmacy that you can't get anywhere else. And it's, $40 a month for an SGLT2.
And our major pharmaceutical companies have amazing patient assistant programs.
Absolutely.
So some of them are up to 4 times that of poverty. And so at our facility, we have across campus, we have an office. That's all they do is patient assistance. And they have to provide some tax forms and things like that. And then the folders come over and I sign off it. And then they get their meds and their needles for free or such a reduced price. We actually have 2 full-size refrigerators in our office just for patient assistance that's being rotated in and out with their names on it. They're generally not sent to the patient's homes. They're sent to us and they have to come pick it up. But so remind our listeners that patient assistance, these people are super generous with poverty guidelines.
Yes. And a big shout out to the drug companies that do that, because there's lots of patients that get their medications that way. Yep. The only last thing I want to talk about with GLP-1 RAs is just those prescribing pearls, the things we really need to screen for or just warn patients about. Like if constipation's already an issue on your patient who may be eating a lot of fast food and not drinking enough water, or they already have bad reflux, eventually it'll get better as you lose weight. But let's talk a little bit about what you say to patients when you get...
Yeah, and that is a great way to end this up, because again, these drugs are so good. Without good clinician education, okay, talking to them just for a few minutes, we are slowing the gut tract all the way down. If you have heartburn issues, if you don't change your eating, you'll have more heartburn issues. If you have constipation issues, if you don't change your eating, you'll probably have even more constipation issues. And so, if you look at the package insert for all these drugs, it's GI in nature. But what's amazing is in the clinical trials, like 90 to 95, maybe 96% of patients finished a forced titrated clinical trial. And doing clinical trials, I do know that they're counseling them about how the drug works. So we just need to spend just a few minutes saying, hey, slow down your eating. When you feel a little bit full, do the push-up diet and push up against the table. You can always go back and you can pop your food into a microwave 2 hours later. If you're going to go out with your spouse, share the meal. Okay? If you're going to go out and treat yourself for lunch, put half of your food in a to-go container as soon as it lands on the table, because no one's going to go back and eat the rice and beans 3 days later. So give yourself a good lunch for tomorrow. So just doing some really good education. And then you mentioned constipation. I think that one's a deal breaker, because if you have constipation and you have worsening constipation, you're never going to go back to it. But one of my patients who did so well on this class of medications and also lost just a bunch of weight, had constipation. And how he fixed it was, and I've told this to many of my patients, is he would just eat a can of beans for lunch. I don't mean green beans.
Yep, I remember this story.
Yeah, black beans, and eating cold black beans out of a can. I said, you gotta be kidding me. And he says, no, and Gary, on days I want to treat myself, I buy a can of ranch beans. I said, what are ranch beans? And he says, well, they cost 10 cents more and they give you a shot of Tabasco sauce. I was like, go figure. But he's done so good. His constipation's fine. He's lost way more than what we see in the package insert as far as a weight reduction. So I think using our skills as clinicians, we can avert a lot of that GI side effect. As far as any other things, it's really just GI in nature. There's no glucosuria, so you don't need to worry about that or anything. Yeah.
No, I do think I've seen some patients, so retinopathy is a concern, especially in patients who've had poor control, and now we're pulling them into control. So just like pulling a type 1, they have vision changes sometimes, but getting that eye exam and marking that down, so your HEDIS score is fantastic, but also you've had an eye exam before.
Got to get that yearly eye exam for sure. And think about it this way, and we've seen this in our basal bolus insulin trials too. When you take someone with a really bad A1C that's already had some diabetic retinopathy or background retinopathy, and you bring their blood sugars down to euglycemic numbers super fast, that friability of those vessels gets worse. Mm-hmm. And so it's probably happening just because the retinopathy is happening because you're bringing them down so very quickly. And so it's a good idea to ask that question. Another thing that we've added that's been added is, hey, our anesthesiologists now want to have control over their diabetes all of a sudden because they don't want to have any kind of aspiration. Great, we want to work with you on that. But these drugs have such a long half-life. You'd have to stop it 3 or 4 weeks in advance to get it all out of their system. So I think working with our anesthesia folks, maybe having like a clear liquid or just a liquid diet the day before might be enough to get that through. And so I think we're all working in the same direction for that. But that is a change to the package inserts. We need to just keep that in mind.
Yeah, although I went to look it up at the American Academy of Anesthesiologists, and they're only recommending 1 week because, like, who wants to pull their diabetic off of a med for 4 weeks prior to surgery? Just makes me nervous.
Yep.
Wound healing and all of those things. Pancreatitis, especially with the so much an issue with this, or DPP4.
All the incretins, and I'll include the DPP4s because we didn't talk about DPP4s because DPP4s were kind of a flash in the pan. They came out 0.7 A1C reduction, but truly the GLP-1s have just squashed their ability to really grow. But yes, that would be something to be concerned about with that. So yes.
Okay, so monitoring. So if they have any history, of course, and we know the thyroid cancer, the men's cancer and thyroid issues. But...
Yep. But in my personal practice, I've never had anybody that I can associate pancreatitis, and I've got hundreds, if not thousands of people on these classes of medications. In fact, the only one that did was on a DPP4 inhibitor. And so, these people have hypertriglyceridemia. They may have alcohol issues. There's lots of reasons why, if I've corrected their triglycerides and they're no longer 2,000, would I feel safe adventuring into? Yeah, I might, but I would give them a lot of education about what pancreatitis looks like if they've never had it.
Yep, agreed. All right, I appreciate that. Any parting thoughts? Any things that any APP should really be thinking about because we're doing so much type 2 diabetes management just in primary care now. It's not always getting...
I say this at our conferences. I say, hey, you guys can be the nurse practitioner diabetic star in your office. I'm telling you what, this is a super rewarding field. It's a super rewarding thing to see your patients get better, losing some weight, having control over their life, losing weight, exercising, and then all of a sudden their family members are saying, well, what's happened to you? Well, I got my diabetes under control. So I think as nurse practitioners, we have a unique opportunity because a lot of our physician colleagues don't take that same passion that we do with diabetic patients, I think. And so, you could be that Lone Ranger diabetologist specialist who really makes that connection with 1, 2, or hundreds of people's lives.
Completely agree. I appreciate us going out on that note. Thank you, Gary, for being here with us, for taking time.
Thanks for asking.
You're one of the best teachers on endocrinology I've ever had. And so I really appreciate your time with the NPACE audience. I know everybody's going to want to hear this. We will have continuing education on this. It's going to be posted with the objectives. There'll be a few pre and post test questions, but a big thank you to Novo for supporting this education because so many adult patients have type 2 diabetes. So to our audience, be sure to check out npace.org for information on all things NPACE and our learning center at learn.npace.org. And we have other CE programs there if you need it. We have education programs by Gary Graf, who speaks on more than just diabetes. And we welcome you to all visit npace.org to see where we're going to be in person on everything NPACE. Thank you, Gary, for being here with us.